Could I have my slide number 18? I have the questions we were to discuss. And next slide. Okay. I think, have you answered the first question? Or are there other toxicities that we have to consider?
Well, I think that this is really the issue of today's event. Of course, it's quite interesting to see other targeted therapies causing other kind of side effects. I would want to mention trastuzumab in this context, which has the surprising side effect of cardiotoxicity. Although the large HERO trial showed that this might be only the case in a very limited number, a very low percentage of patients, and might have been overestimated in the past. But still, that is something which is quite interesting. And I think it's interesting to see, because we don't quite understand biologically what we're doing. This is really the fascinosum for me here in this context. That, for instance, bevacizumab would increase bleeding and thrombosis on the other hand, or wound healing problems, or things like that. So we might have arrived at very interesting drugs. However, they pose a lot of questions biologically, which we really are not up to answer yet. That's what my rather prejudice is. Or
Can I ask you something? Because I remember, I think yesterday, my research nurse said to me, did you realize that we don't see so much grade 3-4 skin toxicity in our head and neck cancer patients than in our colorectal cancer patients? And now that I saw your figures, we have not more than 3% of grade 3-4 skin toxicity in our head and neck cancer patients, but you have about 15% grade 3-4. You have any explanation for that?
I wanted to come to that was also the reason why I included this Lucas study here, because I thought this might be also disease related. Because you only have 5% of skin toxicity in the Lucas study in the non-small cell lung cancer patients. So what I considered was that this might be very much disease related because, well, this is only speculative, of course, and we are speculating now. But this could very well be that certain diseases lead to certain biological processes which we influence by different ways.
But skin is skin, no?
Well, I'm not so sure. I'm not so sure. Because, for instance, when you look at the local reactions happening in skin, this is an enormously immunologic organ.
Do you think that smoking can have an effect on that? Both lung cancer patients and head and neck cancer patients are smokers.
Smoking could have an effect on cytokines, on the release of cytokines, and this is manifest in the skin.
Could this be an effect of the downregulation of immune response in head and neck cancer patients?
That's what I think that what we're seeing in skin is very often just the result of immunologic up and down regulation. I mean, you're not allergic in your you're not allergic in your heart. You're allergic on your skin usually. I mean, allergies are. Okay. You don't get diarrhea when you have allergy.
But to go back to the debate, we are discussing now, we should add life
quality
to years.
Of life.
And a lot of our data reports are adding years or months to life. And you suggested in your talk that we actually should increase the side effects in treatment. Is that the right way to go?
Well, I know this is provocative, but we do have here something. Which I would consider as quite clear related to the effect. We obviously can measure the quality of a response via a side effect, which is unusual, really, or unknown to me in medicine. That you have something which is a paradigm for your treatment response. occurring in up to 100% of patients.
Okay, but what quality of life do we give our patients?
Right. So the thing is that you come to the bed and the patient is desperate because she developed acne, and that you are happy because she developed acne. And I try always to tell the patients, well, the thing you are upset about, we're happy about, because this is something which is for us, it's a positive sign, which is unusual in medicine.
Yes.
That's why.
Yeah, it's rather unique.
Right.
Yes. What do you say?
I was thinking that we are always now for target therapy speaking about toxicity, which we know that it's not quality of life. Quality of life is something that the patient says what his quality of life, and then toxicity is something that the physician says and rank somehow. So to me, as far as the literature is concerned, I think that it's too early to speak about quality of life in the real sense. I mean quality of life by means of measurement through questionnaires through validated questionnaires. As far as I know, the Bonner trial has implemented quality of life evaluation, and yes, because I've seen them.
Really?
Yes, and I couldn't have had this opportunity to bring it to you. I asked, but it wasn't possible. And they measured it with some form of questionnaire. I didn't remember which one was. I think it was something about your TC, but I didn't have the opportunity to bring it to you. The main question to me is, on one side, for chemo, radiation, and for surgery, we have some quite solid data about quality of life, which are very interesting, and to me it is too early to speak about quality of life in target therapy. We are still thinking, and we are still speaking about toxicity, which is a surrogate, might be a surrogate of quality of life, but we still don't know which impact has skin toxicity to the patient. We might have some information about some long-term sequelae of patients developing after chemo, radiation, or after surgery, and which is the impact on quality of life, because there are some interesting data of it, but not of as far as target therapy is concerned.
That's why I rather concentrate on toxicity,
yes,
because there's no data.
Well, I'd like to make a couple comments. The first was in regard to the toxicities that you're seeing in different populations. It may also relate to the other systemic agents that are given concurrently with those, whereas irinotecan is given more for the colorectal patients versus agents used for head, neck, and lung. Regarding toxicity, we haven't commented on long-term toxicity, and that's because there's not a lot of data out there. I think it relates to what my colleague just said, that some of the long-term quality of life may come out related to late toxicities, if there are any, so it's too early to tell on that. Our experience in patients given induction chemotherapy concurrently with cetuximab in about 48 patients in a study we just completed accrual to is that the rash was fairly significant and troubling to some patients, and wonder whether that will ultimately lead to compliance issues in other settings. For advanced cancer, it's easy to justify that, but for example, there's talk of a study using cetuximab in the setting of a chemopreventive agent. So someone that doesn't have cancer to get this potentially troubling rash may not be something that they want to do. And I think, just as we can't study the oncologic aspects without looking at quality of life, we can't look at quality of life without the oncologic aspects, and we really need to know where these drugs are going to fit, and I think the randomized trials are going to be important of adding cetuximab or comparing cetuximab head-to-head with chemotherapy will be critical. I think that we heard about the few, one death with hypersensitivity and a higher rate of patients, maybe as high as 3 or 4%, that have these hypersensitivity reactions. We'll have to justify that really showing a benefit in survival.
Do you think we have the appropriate instrument questionnaire practice to measure the patient appraisal of the new toxicities? Because we get the answer dependent on the question we pose. Or do we need new instruments to follow new toxicities?
Well, I wonder whether these new toxicities that we are talking about, whether they are adequately addressed in the questionnaires that we have. Personally, I must say that I find these questionnaires very tiresome. I find them too large, too big. It's also clear that in trials that are being performed, that at baseline everyone is doing it, but it drops tremendously in the time, over time. And so we have had also experiences in the EORTC head and neck group that starting is okay, but then after 3 or 6 months it goes down. And so if you're not having the system in your hospital that you have people that are sitting on this and putting this forward to the patient every time, you get a selection of patients over time. You see that in the literature also. You see that they start with 50 people and then they have the results on 25, but they don't have it on the 50 people. So you get a sort of selection bias every time. So if we want to do quality of life assessments, I would think that the forums should be simple, not too much time taking, and really addressing the issues that you want to focus at. And personally, I find these 3 pages questionnaires tiresome.
That's one of the reasons why I showed them, because they are rather dull. And you have to remember that were probably constructed in the late 70s, early 80s. And we have developed therapy a lot since then. How did they evaluate the quality of life in this study you referred to, Dr. Lucic?
I don't remember. I think it was URTC, but I don't remember really. I think it was for a subset of patients, the randomized subset.
Dr. Gerald, is
it? Yes. Ah, you know it. Thank you.
It was evaluated by the general questionnaire and the head and neck questionnaire.
You know the results?
We'll show you later.
Oh, good. Good.
Okay.
I can't claim to be an expert in quality of life instruments, but there are more specific instruments for swallowing issues and speech issues related to head and neck cancer. There was one developed at our hospital, but they suffer from the same problems of, it's a lot for patients at times to go through, especially sequentially. Maybe the first time they're interested, but as time goes on, it gets harder to get compliance with that.
I'm always thinking, is it a matter of physician interest, or is it a matter of patient interest in filling in all this questionnaire? Because if it is the patient, then it's okay. If it is the physician, then we should look whether we should work better.
No, but that's why I said you must have the structure in your hospital that you have a dedicated person that is bringing this to the attention of the patients every time. If you don't have that and you just leave it to the doctors, it will not happen adequately.
Even if you had the opportunity to read a questionnaire after an outpatient clinic visit of your patient, then a world opens to you. You get a lot of information from this questionnaire, which we really don't take into account, because we are always taking how did you slept, how is your pain, how many times did you have vomit, and so on. So I think that it's a pity that we don't use all this information. And in this way, I think we lose an opportunity to take the results of this questionnaire to inform patients, further patients, about dramatical choices. Let's think about surgery and non-surgical procedures, which of course is different the treatment and different the outcome in terms of left sequelae. So I think that we missed an opportunity with this quality of life informations, not to use them to inform patients and to help us with them in their clinical decision making.
That's correct.
One of the issues that I have problems with in the quality of life is that you have difficulties comparing the impact of the side effect or of the toxicity versus another one. It's very difficult to find the right words, but for instance, grade 4 or grade 3 skin toxicity is not such a drama as compared to grade 3 cardiotoxicity, for instance. Yet it is grade 3, and we put there grade 3. So, for instance, if you would have grade 3 cardiotoxicity, you would stop treatment. If you have grade 3 skin toxicity, you discuss this with the patient, and it depends how much the patient is influenced or how much the patient is depressed about that. But this is something what I have difficulties with, that we are having these grades, but not weighing the problem that we're measuring. And the other thing is, and that is something which we might want to reconsider talking about targeted therapies. And the other thing is also the effect that is being reached, because probably one would have to ask the patient this kind of toxicity versus what you would have without it, which is a hypothetical question and very difficult to answer for the patient. But still, is an acne something which is terrible to the person or to the patient, yet associated with better local regional control, better survival, etc., or is it not? So we're coming into a little philosophical kind of questionnaire, but still it's probably much easier to be answered than, for instance, if you vomit yourself to death, because before I remember the era before H5-HT3 antagonists. I still remember treating patients with testicular cancer. They almost died when I got there in the morning after platinum-based treatment. So and they even verbalized that and said, before I vomit myself to death, I do not want to have this kind of chemotherapy anymore. The elder of us remember this very well. Yeah. So probably one has to weigh this kind of side effects a little better.
Okay. I promised we should finish within 5 minutes after the time we were allowed. And I have one question. When we do this, can we accept higher toxicity for the targeted therapy in order to reduce the toxicity of the combined treatment? So we do not gain for example, you can reduce the cytostatic treatment, the side effects of cytostatic treatment, and then you don't gain in month survival, but maybe you gain in quality of life during the period of palliative treatment. Is that a possible option?
Well, that happens partly when you think about platinums in combination with trastuzumab. There you reduce platinums because of the synergy. You can do this. There's data by Edith Perez out where she used weekly Taxol 90 milligram per meter squared and carboplatin AUC2 combined with trastuzumab, where you once you have synergy, you probably can start thinking about such trials.
Well, but I must say that if I have to choose for carboplatin, I think I would keep the dose of carboplatin and leave out the other compound, because the side effects of carboplatin are really not very serious.
Right.
So you have to balance that, really, I think. So if you add a new compound with a different pattern of toxicity, then reducing another drug which is not so toxic would not be, for me, a solution, I must say. Because we do very easily about skin toxicity, but if you see sometimes what the patients are showing you, that is not something you have to underestimate, I think. And there are people who are refusing the treatment. So
I think that the answer is not there yet for head and neck cancer, but we're in an exciting time where we can address these issues. And going back to the induction study that I just spoke of, We had patients with mostly stage 3 and stage 4 disease that had fairly brisk responses to carboplatin and docetaxel and cetuximab. And now we're at a point where we're asking in those patients, should they go ahead and get their concurrent chemoradiotherapy, or could they get radiotherapy alone? So a lot of them had rashes. A few of them did have hypersensitivity reactions, but those are short-term investments and potential long-term benefit of perhaps not needing to give the concurrent chemoradiotherapy. And I think we'll have to come up with criteria by which we can make a decision before moving on to concurrent therapy. And I think this is an exciting area.
Thank you.
Can I ask Dr. Zielinski about what I find sometimes also difficult for the patient is that the tiredness that they have. That is not always scored so very well, I must say. Our scoring system is not so perfect in that respect. And it's one of the major problems we're facing now. In the past, I still remember the research that Alan Coates did when he was looking from what were the most severe side effects. At that time, the one top on the list was nausea and vomiting, and now it's tiredness and fatigue. And so also with the newer agents, fatigue is one of the major problems.
Even if fatigue, to me, is exactly the symptom which will be reflected on quality of life scores. On which, in particular, I don't know, because it's very difficult to some questioner has the question, the item fatigue, some other not, but probably this symptom will be included in some aspect that we are measuring.
Okay. I have one last question. Could I have my last slide? I like this because every time we get a new therapy, there is a high degree of enthusiasm. I remember when the platinum came and it would cure anything. I think we can agree we are on the upgoing side of the curve right now. And my question to you is, where will we be in the future when we have all the knowledge we ask for today? Will targeted therapy give our patients better quality of life?
Well, I think there's something I can't remember the exact term called hedonism creep, where you'll once you get your new car, then you want a nicer car, and then when you have a nicer car, you want a second nicer car. And I think the same thing, if you keep improving the baseline, we'll still, see areas where patients' quality of life can be improved. But I do think that, these agents provide an opportunity to study better ways to decrease toxicity, short and long term, hopefully. And I think that what we see as quality of life as the providers will be better than we saw in our patients many years ago, like this anecdote we hear about, nausea. On the other hand, the patients have a different baseline and may not realize how much better off they were.
Dr. Zielinski, what do you say?
Well, I must say that I'm extremely worried and confused because we find this more and more targets. And we find more and more compounds which hit more and more targets. And I somehow see that in the end there will be 35,000 pharma companies producing 35,000 compounds for 35,000 patients. And I don't see quite where we're going right now. There's a lot of enthusiasm about targeted therapies. The problem is that I think that we're spoiled brats because we have had this sort of bad luck that we discovered compounds which hit at a certain target, which was decisive for the cell to divide, and by using old kinds of measuring the efficacy of these drugs, we came to the result that everything was beautiful. Like, for instance, Gleevec. Gleevec was directed at a very decisive mechanism, made 90% responses, and we measured this by disease-free survival, overall survival, and everything was fine. Right now, things are becoming more and more complicated because we don't know what kind of signal we want to hit. And whenever I come back from an advisory board, I find everybody there desperately looking for some kind of answer how to measure which result and which mechanism is to be influenced. And when I see a lot of compounds being developed for and being tested in entities which are very rare. Like, for instance, there's a lot of trials going on, for instance, in glioblastomas, which is a rare disease. I find that we have to find some kind of surrogate markers, and we have to probably start thinking in different categories than we were thinking until now. And maybe quality of life is one of the issues. But I think we have to define ways to define efficacy better than we're doing this until now, I guess. I think a lot of things are exceeding our intelligence.
I really don't know.
Frank?
Well, I'm absolutely positive. I think that, I maybe have been critical about that we should look for how to evaluate the side effects and how to score the side effects and how to register it, how to score it. But I think I'm convinced when you see what happened with the Gleevec, for instance, when you see rituximab, when you see the possibilities of older patients that can be treated more adequately now because we have treatment which is better tolerable for them than we had in the past. We should not be negative about the fact that some of the side effects are disturbing. We will find a solution for that, ultimately. But I think that we are living now in a situation that we have a new approach to how to develop new drugs. It's much more intellectually than we did it in the past, and I'm convinced about over the last 5 years I have seen drugs that I've never seen before, and I'm positive. I put that on the top of the curve, I think.
Thank you. Then we can conclude there is light in the end of the tunnel of side effects.
Yes.
I would like to thank the panel and Professor Zelinsky for excellent talk. Thank you very much.
Thank you.